Thanks everybody for coming. We really appreciate it. We hope this is informational. We've got a lot of information. There's a lot more that we can share that's not in the slides. So we're happy to connect and answer any questions that you have. Just to review the agenda very quickly, we want to review our system-wide improvement journey. And I think it's important that we called it a journey because this is a journey, and you'll hear about that, about why that is. Discuss how to develop advanced organizational capabilities to drive the improvement, leveraging analytics. We'll obviously share some results, and then we'll share some key lessons and describe what's next. We have a few learning objectives. Statewide executive engagement and support is critical for transformation. Explain why standard and systematic improvement methodology is required, and then articulate why the ability to analyze problems is so important. Who are we? This is our standard community health network slide. So we're in Indianapolis, 9 acute care and specialty care hospitals. You can read the other statistics. We're an Epic shop, and we've been with Health Catalyst for going on about 5 years. So, poll question number 1. On a scale of 1 to 5, how would you rate the healthcare quality in the United States? Incredibly poor, poor quality, adequate quality, moderate quality, incredibly high, or unsure. How would you rate it in the United States?
So again, this is session 14, question number 1. Go ahead and get your votes in. Right now it looks like 2 options are both at 33%.
It's almost like a perfect bell-shaped curve.
It is. Look at that.
All right, good. That's right. So I think we started on this journey, like many other systems, knowing that that healthcare quality must improve. Everybody's familiar with the statistics of quality in our hospitals, quality in our ambulatory settings, and a lot of the poor quality or some of the poor outcomes that occurs from lack of a standard improvement methodology. And so we started on this journey actually longer than 5 years ago when we started with Health Catalyst, and Travis will jump into some of that. We've been training many of our caregivers on Lean Six Sigma for many years. And what happened about 5 years ago was we reinvigorated the need. We had an executive from the board all the way down, an executive understanding that we needed to improve our quality. So we had the support to move forward. But we had several problems that impeded this initial start to the journey. One was we didn't have a systematic process of improvement. We had a lot of improvement. We had people that were using Lean and Six Sigma and other methodologies, but we didn't have a standard across-the-board approach to analytics or process improvement. This really resulted in a culture of optionality, which I think a lot of people can probably relate to. Earlier today, listening to Daniel Pink about autonomy, mastery, and purpose. A lot of caregivers, a lot of people that go into healthcare are really purpose-driven, but what you hear about burnout and everything else is you're taking away my autonomy. I've studied for however many years to be a physician. I've been a nurse for 20 or 30 years. You're taking away my autonomy, and what that resulted in our organization was this culture of optionality where when we had standard processes, we didn't have the data or analytics to back that up or to show the outcomes or to show the alignment with those standard processes. We had some other problems. A lot of our project improvement work or process improvement work was really project focused, and it was siloed. So you would have one ICU doing an improvement project at another hospital, another ICU was doing a similar but a little bit different improvement project. We didn't have across-the-board communication, and it was really siloed, and it was really whatever somebody had come up with or that they identified, which was great because it's grassroots, it's frontline caregiver driven. They're the ones that know the issues that need to be improved, but we didn't have that feedback loop to the higher levels of the organization and then down. The other piece of it was a lot of the improvements that were going on didn't really tie to our strategic objectives of the organization. So we may have a lot of improvement going on in an area that was using up a lot of resources, but the organization had said strategically, we need to focus in this area, and there was not the alignment that we needed. And that really goes back to the last bullet point of lack of a formal governance structure was really limiting our improvement efforts. You want to read the next question?
Yeah. Poll question 2, on your apps, on a scale of 1 to 5, how would you rate your organization's effectiveness in introducing and implementing change? So 1 being not effective at all, 5 being extremely effective, and 6 if you're not sure. So take a few minutes and submit your poll response to question 2.
Okay, let's start to look at some of the results coming in. Looks like 42% right now are saying that they're moderately effective.
Moderately effective, that's pretty good.
That is good.
Yeah. So Patrick, Dr. McGill went through some early slides talking about some of the kind of friction points that we had organizationally. How many of you could relate to some of those bullet points? Are you facing, I was hoping a lot of people would raise their hand, because I think they're fairly common opportunities healthcare systems are kind of trying to address. So I'm going to kind of pick up where Patrick left off and talk about some of our organizational strengths and enablers that helped us address some of those things and kind of where we are current state in addressing those. This is a photo of the University of Georgia weight room. This is where Dr. McGill went to undergrad. And this
I didn't spend a lot of time in that weight room.
Oh, I thought, yeah. You told me you did.
No.
Yeah, all right. So we can redo these slides, but it was just meant to imply that, we organizationally, in all of your organizations, you have some organizational strengths that can help you along the way. And we found at Community that we had some organizational strengths that helped us along this journey. They're outlined here from a very high level. As Community Health Network had a high level of caregiver engagement, top decile performance from a cultural perspective. So we have really empowered, engaged caregivers that results in high patient satisfaction scores too for our patients. So, they've got this willingness, but what we're finding is it's acts of heroics that these nurses and providers are making these exceptional patient experience. It's not grounded in process. So we've got that as an organizational strength. As Dr. McGill alluded, we've been doing process improvement since January of 2008. So we've had a head start. We had a runway going into this work. We had, when we first started, we had 2.5 members of our performance improvement team. How many of you use Lean Six Sigma right now, kind of in your shops? Probably half the group. So one of the things is we started to mature our thinking around Lean and Six Sigma and the improvement sciences. We took a lot of pride in the performance improvement team to use terms like regression analysis, multivariate studies, DMAIC, and we'll talk a little bit about our playbook. And we kind of wear those things if you're a performance improvement expert. It's like a badge of honor. But when we talk to 16,000 caregivers and we start to use terms like that, guess what? Does that drive engagement? No. But we're slow learners, so it took us like 10 years to figure that out. And we'll talk about a playbook that I think is really important, that I think will be one of your key takeaways today. We have a great partnership with our analytics provider. Can I say Health Catalyst is our analytics provider? Yeah. So
I think I already did.
Oh, did you? All right. So one of the things that I think they helped us is formalize the governance structure. And Patrick talked about, we had all these, what I would call science projects of improvement going on all over our system, but we did not have a governance structure that says, how do you systematically pull these things together to make sure that we're honoring people's time and resources and being good stewards of the organization. And this governance structure that Patrick will talk a little bit about later, I think is a key to our success and kind of where we're going next with some of our next levels of maturity. And then also through our partnership, we had some access to some advanced training and development opportunities around data and analytics that I don't think we would have had we not had this partnership. So overarching goals, any marathon runners in here? This is a picture of Desi Linden, all right? Des Linden won the Boston Marathon in 2018 in quite possibly the worst conditions the Boston Marathon's ever seen. Temperature was 34 degrees. It was freezing rain. And for those of you familiar with the Boston Marathon course, it is an out and back. And there happened to be a headwind from Hopkinton all the way back down to Copley Square, which is where the Boston Marathon finishes. So
Travis did finish the Boston Marathon.
I was in that race with Desi, but I was like an hour behind. So I ran with her. She was probably having lunch or dinner by the time I finished, but nonetheless, I was cold. So the two bullet points here that Dr. McGill and I wanted us to kind of call out here is, how do you ground an organization of 16,000 people around kind of a common mission and vision? And one of the things that we wanted to highlight here was we felt like it's important to develop core organizational competencies around analytics and process improvement discipline. And the more we work, you're starting to see things like Industry 4.0, if you follow ASQ, is that what typically has been process improvement and analytics, those lines are getting really blurred, and they're becoming almost indistinguishable. So we want to make sure organizationally we're building the right competencies around that. And then we believe that if we can accomplish one, that'll help us achieve bullet point number 2, and that's our aspiration of becoming, we want to achieve top decile performance in the metrics that matter most to our patients and community health network. And this is our aspiration for quality. And Patrick,
Yes.
I know you are key in developing
Yeah,
this.
so this was really the rallying cry from the board. This was a board level adopted goal. So our quality will position Community Health Network as the provider of choice, delivering the exceptional experiences, outcomes, and value that each customer needs and expects. So a little background on this. Our, at least in our ambulatory side, our customer or patient experience has been in the top 3 for the last 4 or 5 years. Our inpatient experience is in the top, I believe it's in the 75th percentile. Our caregiver engagement, so our physician engagement, has been for organizations that employ 250 or more providers, number 1. So our physician engagement has been off the charts. So we felt like we had a lot of the building blocks to take on this work. There had been other work to kind of lay the foundation with patient experience and caregiver experience and physician engagement and the performance improvement team. And so this was really from the board and the executive, the ELT, the executive leadership team, achieving this aspiration for quality, and what we will talk about here in a few minutes. That was a board level metric. That was an ELT incentive level metric. So we had the engagement from the top down. And I think that is a key driver. That was a pivotal point in this journey. There's going to be several that we highlight, but this was really one of the pivotal points. And again, we use it as a rallying cry of this is what our patients expect. And we've actually evolved this now, so we're 3 years into the aspiration for quality, that we've evolved it to not an aspiration for quality, but an expectation of quality. So that we expect, this is what we expect from our caregivers, our physicians, our leaders, our executive leaders moving forward. And that has also been adopted from the board level down.
Yep. So this next slide, Dr. McGill and I could probably spend 39 minutes, 34 seconds on this. You're laughing about the photo. So on the left is Dr. McGill's mom. On the right is his dad. And guess where Patrick is? Right in the middle.
That's right.
No. So closing the gap. This is a really good summary slide of kind of moving from on the left to where we're moving to on the right. So Patrick just did a good job of kind of giving you the background of the aspiration and how that came about. This limited senior leader support to that board level commitment has been, if we were using Daniel Pink's method, this would be one of the top 3 things that I would want you all to take away, is that this has been so big for us to have that board level commitment behind analytics and improvement. They're asking about this work every month. to our CEO, to our executive team. It is definitely on their radar. And limited senior leader support, this probably looks to you similar to what it looked like to us. We have a lot of willing and interested senior leaders. So a better term for this might be variation in senior leadership support, because we'd have senior leaders that would want to sponsor improvement projects. But what does that even mean when you say sponsor? Does that mean your name's on a charter? Does that mean I'm showing up to the team meetings? So there's just variation in what that meant to senior leaders. But overall, they were willing and interested in supporting this vision of the aspiration for quality. We're in the early stages of developing capabilities around process-based management. That's a term. Has anyone heard of process-based management? It's a subtle difference. It all comes from Deming and his work, but it talks about how do you build organizational competencies around how do you manage, design, and improve processes. It's not just the improvement piece. So we're trying to learn more about all three of those components, and there's a slide coming up that will talk a little bit more about that. So multiple improvement approaches, was the reality. So we had Lean, Six Sigma, PDCA, design thinking. We used some of the GE cap and workout models. And what we were finding is that started to paralyze the organization's willingness to interact with us, because people were trying to decide, is this a Kaizen event? Is this a rapid improvement event? Is this a PDCA? When all at the root level of this is we're trying to help our caregivers solve problems. So that helped us kind of mature into this standard improvement methodology, which Dr. McGill mentioned, which is what we call the Way We Improve playbook. And we've boiled all of those improvement sciences down to 7 simple questions. And it starts with what problem are we trying to solve? So imagine when you're in a room of frontline and first-line caregivers, and if you were to say, we're in the define phase, what does that mean? Or, what is the problem we're trying to solve? And I think we heard it on the main stage today from the keynote speaker. So it went from just kind of this intimidating terminology we would use to this inviting, open, welcoming terminology. And the playbook is another one of those things that I would list in the top 3 things that I think have been key in helping us advance. Talked briefly about having no formal governance structures. Patrick will talk about the structures that we have in place around cabinets, councils, and work groups. And I think one thing that I've learned, especially in my role, is that we didn't have a formal analytics structure in place. And Dr. McGill is Community Health Network's first chief analytics officer. It also helps tremendously that he's a provider. There's rooms that Patrick and I can be in, and I could say the same thing that he would say, and a provider would much rather listen to Dr. McGill than me. He's just way better looking.
That has nothing to do with it.
Right. So there is something.
It's true,
that
even if we're not talking about healthcare and improvement.
Yeah, well, that's true. Yeah. So there's something that's, when Dr. McGill got in his position, we did see an acceleration because he was able to get to a segment of our workforce that we just haven't been able to address before. And you've seen these providers coming to the table, and they're rapidly engaged in this type of work. And I think it's just because of Patrick's work in helping get this analytics department stood up.
So these are the four key drivers, or the 4 steps. I think we've covered most of these. Started with executive level engagement, implemented a standard process, and then implemented a new governance structure. We'll talk just for a minute or two about what the structure that we put in place. So we aligned with the care process model that Health Catalyst uses, the care process and the care process families. And internally, we call service lines, what a lot of you probably refer to as service lines, we call those product lines. We've done that for several years because we expect them to be outwardly facing, whereas the patient is the customer, the consumer, whatever word you want to use. And so sometimes service lines tend to be internally looking, and we expected the product lines to be externally looking, especially when it comes to growth and variation and value-based care. So each product line had what we called a cabinet. That was made up of the product line leaders, physician, administrative leader. We had finance analysts embedded in that cabinet. Other operational and clinical leaders were in that cabinet. The role of the cabinet was to really define a strategy, the improvement strategy, and make sure that that improvement tied to the network strategy. So women's, for example, chose substance use disorder. Orthopedics had joint replacements and lowering the cost of care of joint replacements. Primary care chose a lot of the quality metrics that we're held accountable for in value-based care. So what that created is it created a structure where you had clinical leadership buy-in because the physician leader was responsible for connecting to the other physicians in the organization. You had operational leadership buy-in, the operational leader, and then that trickled down to a to a council. Council is really around a specific process. So in cardiovascular, you might have heart failure or AFib. And again, we just followed the same catalyst methodology and just renamed and branded it our own. And the third thing is a work group that's specific to a process that needs to be improved. So you might have a work group in women's on how do we improve our screening of women on their first OB visit for substance use. You might have a specific work group that's made up of frontline caregivers, analytics, finance, nurses, might have some doctors in there to really focus on a specific process that needs to be improved. You also have, Care Connect, our EMR analysts might be in there if you need to have a order set changed or a BPA created or whatever you need in that workflow. They're also responsible for identifying the baseline data, the baseline metrics, and then setting the goal for what they want to improve. And then that cascades back up to the council and the cabinet. Like Travis said, when we improve the process discipline, we develop this community way excellence framework and develop the skill required to answer these questions, the key questions. How do you improve processes? How do you manage processes? And how do you design processes? One of the things that he said a minute ago that I think is really key is we spent the first 12 months in various meetings, and you would hear all this dialogue and all this chatter about different problems, and we need to do this. And it was really the two of us plus about 15 or 20 other people, because it wasn't just the two of us, this was a team event, or teamwork, really would stop people in the middle of a meeting and say, wait a second, what problem are we trying to solve, and how do we define that problem? We're all problem solvers, so we immediately wanted to jump to the intervention, and this is what we need to do. This is what you need to do to fix that problem, versus really walking through the framework. And so really slowing people down to walk them through the framework was another key pivotal point to getting buy-in, because then they would start to see, okay, we've defined the problem, we know where we are, we know where we want to be, and now we've identified the root causes. And that was probably one of the biggest barriers that we had, was people wanting to jump to the interventions and not necessarily following the framework.
Does anyone use the Baldrige framework to drive kind of your organizational performance? No one? Okay, maybe one. So that framework that Patrick talked about we've adopted that to create the Community Way Excellence framework, and that's one of our assessment tools to help us measure our maturity on those 3 questions that Patrick talked about. And Patrick talked about the playbook. This is what it looks like. It's probably a 50-page document that just outlines the 7 questions Patrick talked about. And it is really fascinating now when you sit in a meeting at Community Health Network, you'll hear physicians and executive leaders engage in a dialogue, and if that meeting's going off track, someone in that room almost always pulls back and says, what is the problem we're trying to solve here? 12 months, 24 months ago, that wasn't the case. So that's kind of one of those signals to Dr. McGill and I that this is getting embedded in our culture. And I think that just by making it easy, based on these 7 questions, do we understand the problem? Do we know where we want to be? That's what we use as SMART goal. We've trained the organization around SMART goals. Do we know the root cause? Those first 3 questions are what we call the diagnostic journey for those teams. And to Patrick's point, we've intentionally spent more time on those 3 questions because a problem well defined is a problem half solved. So we've tried to reinforce that throughout the organization. Not until step 4 do we get our work groups thinking about interventions. So steps 4 through 7, you can kind of see on the slide here, go through, do we know what we want to change? Have we applied and measured the change? Did the change result in an improvement? And then how do we spread and sustain those gains? And Patrick was pivotal in writing the playbook. He was being modest, but he had a lot of influence on that. What would you add to the playbook that I maybe missed?
I think one point about the playbook was every 6 months or every quarter, we have something called a Leadership Development Institute. So it's the top 1,000 leaders, managers, and above in the organization meet for a day around different topics. In the early stages, one of the breakouts that we had at LDI was a training around the way we improve or the playbook. Everybody walked away with a copy of this playbook. So they took it home, they read it, maybe. Yeah. But at least they had it in their hand so that the next time, a question came up, or I'm not sure what Tollgate 2 is, or what is this, how do we design an intervention, or how do we look for root causes? They had a reference guide to go to. So I think that was another thing to start to embed it in the culture was this, a couple hour session walking through the improvement methodology.
And one other thing I would add, in the playbook, we've been doing improvement, like I said, since 2008, and we would have variation in the availability of data and analytics that our teams would have. So we would have teams that would have all the data and information they would need, and then we'd have a spectrum of work groups that would have zero data. It's probably you all can relate to that. One of the things that we worked really hard on the playbook is we navigated those 7 questions. We also tried to call out what types of data and analytics do we expect to see at Tollgate 1. So for example, if they're trying to address what is the problem we're trying to solve, at Tollgate 1 from an analytics perspective, we expect to see what cohort they're working on. So in Patrick's example of women for screening, it's obviously women maybe in an ambulatory setting at some age range. And we've done that map all throughout 7 of the 7 questions to help make sure that we eliminate variation in how our work groups are navigating through the analytics. And I think Patrick may talk more about that.
Yeah, so I think the other driver was advancing the adoption of analytics. Obviously, like Travis said, we made an organizational decision about 9 months ago to pull analytics out of IT, create an office of analytics, and create a chief analytics officer so I report to the CEO, so make the analytics a top priority. One of the keynotes I think earlier today said we do innovation, but where's that person report? Oh, they're 5 people down the org structure. So analytics is a top organizational priority. I think this was another key pivotal point to tie what we want to do with improvement to the organizational strategy.
So here's a running joke. How do you know when you meet a runner? They'll tell you. Sorry. He's like, yeah. So I'd like to run. I told you. And this loops back to one of the things Patrick said earlier. This has been a grueling transformation. It is essentially challenged the fabric and status quo of our organization, every element of it. From the functional silos of the organization, challenging the organization from kind of look from end to end through the process perspective, how the organization's structured, how we do our training, how we develop leaders. It's been a grueling journey, and I think this quote here, as you read it, you all may be feeling this, but it's, at mile 20, if you ran a marathon, you might think that you're dead. At mile 22, you wish you were dead. At 24, you knew you were dead. And then when you cross that finish line at 26.2, you realized you were too tough to be killed. There's nothing more rewarding when you cross the finish line of a marathon. And I don't know what our marathon finish will look like with this analytics and improvement work, but I have to believe it's going to be definitely worth it. And this is another slide. Some of you probably connect this to Cotter's change model. We've definitely used that throughout all of our work. And the left is just does it feel like a roller coaster to you all some days? Kind of your ups and downs. Celebrate your highs, don't live too long in the lows. And this is the course of the Boston Marathon on your right. It's just kind of that point to point. So,
all right, so let's jump into some of the results. So we had a goal in 3 years when we started this that we would have 42 measurable process improvements through Tollgate 5. Tollgate 5 is a documented, statistically significant improvement. We had to have 42 of them. So we're about to end the 3-year cycle at the end of this year, at the end of 19, and I think we're at 59 improvements. This says 35. We have a process where we actually submit these improvements to the board, to the Quality of Care Committee, and the Quality of Care Committee will sign off that, yes, we agree this is a documented improvement. So that, again, ties that circle back all the way up to the highest level of the organization. So at the time we did the slides, we'd only had 35, but we're about to submit
59.
another 22 or so. Train more than 800 leaders like we talked about at the LDI. So we'll go through some of the results have been highlighted before, but 15.5 million in savings, 8.2 in sepsis, 124 lives saved. Sometimes we want to focus on the dollars, and when we set out on this journey, when we were tasked with this, we didn't have consistent buy-in across the board. And so what we were told was you need to remove enough waste to offset the cost of doing this. So it had to be budget neutral. So in year one, we had a financial target of 4.2 or 3.5 million. We achieved 4.2. At the second year, we had a target of 15 million, and we were at 17 million. And those are hard dollars, so that doesn't count supply chain. It doesn't count throughput or capacity enhancement. Those are hard bottom line dollars. So you can look at that one of two ways. Either we had a lot of waste, we had a lot of opportunity, which we still do, or there's a lot of hard work that everybody achieved these results. So you can read the others. 2.3 million of primary care savings. The last thing I'll say is at the board level, when we started this, we would report it by dollars because of what we had been tasked to do. And from the board came back and said, yes, we're concerned about the dollars, but we're more concerned about the lives saved. And so now we report it by the lives saved, the lives impacted, and then the dollars that have been saved. And that's how we report it out organizationally to across the organization. I think we have one more slide, and then she's going to ask questions.
You can be first.
All right, we'll hit the key lessons, and then I think it'll be time for questions after that. That's your key.
Oh, this is mine?
Yeah.
Yeah, thanks.
Like
Reflecting on the marathon. So hopefully this kind of packages our discussion, taking away that this is hard work. There's no silver bullet. We've kind of looked for it. It's not out there. We've just had to be resilient and stick to the plan. Senior leadership support is critical. It's easy for Patrick and I to stand up here and say the board level commitment has just been a game changer. It's been a game changer. And it's one of those things that you will see in some textbooks or some writings around kind of organizational change and transformation. But I've seen it play out, and having that board level commitment, and even the message like, I know Patrick delivered it pretty vanilla, but when the board tells you that the finances are important, but the message we want the caregivers, this is all about saving lives. Can you imagine sitting at that table and hearing the board of directors say, finances are great, use that as a balancing metric. What matters most is this work is saving lives. That message, when it cascades through your organization, it shifts the mindset almost immediately, because people, when they engage in the work groups, they think that this is almost always, not to generalize, but almost always, we're trying to eliminate waste and variation to save money. That's what they feel. But if you can frame that and message it from the board of directors like we heard it, it's very powerful. It is extremely powerful. And give each other grace and be willing to learn from failure. We're still figuring out the council cabinet governance structure. We've had so much early success with the cabinet's council governance structure. There's segments of our organization now that believes the only way to get work done is to have a cabinet, council, and work group. So what we're seeing is these things almost organically forming and spinning up work groups. So we've got a different problem to solve now, but it's all kind of positive intent. And then, from a PI perspective, we've really challenged the way that our performance improvement and performance excellence teams had to kind of evolve. If you go back to January 2008, we were using Lean, Six Sigma, and using basic Excel documents. Fast forward to now, where we have closed loop analytics that we're working with and AI, it's really blending and blurring the lines between performance improvement and analytics. And we've had to just be agile and nimble with what that looks like. And we're still going to have to continue to make changes to make sure that we're advancing our analytics capabilities. So hopefully some of this resonated with you all. So we did capture this. This was, Patrick and I took a picture of the crosswalk between Grand America and Little Grand over lunch. So this was people running between the crosswalk, and that was the storm. Actually, that was not the intent of that slide. That was a slide to encourage you all to blaze your own trail. And best of luck.
Yeah. One of the last things we'll say is that we, at one of the, at a different LDI, after we had done the improvement teaching, at that point we had saved about 79 lives with our sepsis improvement. And so we had 79 leaders come up on stage and with signs to represent the 79 people that we had saved. And so what that did was made it real for everybody in the room. And they had signs of things that were occurring in their life. So I was able to see the birth of my grandchild, or I walked my daughter down the aisle, or I took the vacation that I'd been saving for. And so that, you talk about hitting the hearts and the minds. We had tried to go after the minds. We had to get people trained, but that creates the engagement for people to make it real, to say that this is the work. This work is real. We're touching real people. We're saving real lives. And oh, by the way, we're saving the organization money.
It wasn't a dry eye at the LDI.
Right.
It was not a dry eye.
So, okay. Yep. We're done.
All right. Thank you for that excellent presentation, Dr. McGill and Travis. Okay, so now we're going to move on to the question and answer section. And we have a lot of questions that have come up and have been voted on. So we're going to start with the highest voted on question. Sorry, I have to put some stuff down. Okay, our first question is, how do you align and prioritize improvements between analytics and your process improvement areas?
That's a great question. I assume that somebody from my team in the room has that. That's a process that we've continued to evolve. So one of the first things that we did with the Office of Analytics was to develop a standard intake form for analytic requests. We would get analytic requests across the entire organization by email, by phone call, by stopping in the hallway, by I'll text you or whatever. So we had to have a standard process to track it. So that was the first thing. You got to know what the asks, what you're being asked. The second piece of it was embedding the improvement teams, the analytics in the improvement team with the cabinet, council, and work group. They're doing the prioritization. So when the cabinet says this is the highest priority for women's, the prioritization is essentially done for you. So we knew through that process what we needed to work on. Anything you want to add to that?
No, I would still say that it's a work in process for us, because when we stood up those cabinets and councils, Patrick's right. They're self-selecting. They're empowered to select the projects that they want to work on. But now we're asking, well, how do you, from a micro or macro level, make sure all these cabinets and councils are aligned strategically? And we're making a lot of headway there, but we don't have that formal intake process yet, like Patrick
Right.
has kind of described. But that is definitely one of our next steps, and it's hard work to do.
One of the lessons that we learned very early on with the improvements was we didn't have a common way to document. We were not documenting the improvements in a common repository. So they were on people's laptops. Even though you had all the tools, you had the charters and you had the process maps and everything, we didn't have so there was no organizational view of all the improvements that were going on. So common intake form, common repository for the improvements allows the alignment or the prioritization to occur.
So the next question that has popped to the top is, can you talk about how you verified the savings in dollars and lives?
Yeah. So in the Cabinet Council and Work Group, we have finance analysts embedded throughout the whole process. So they're there from the beginning, and they are the ones that calculate the financial improvement. So if your finance department's like our finance department, they don't trust any numbers unless they're given to them by the finance department. So we could come up with predictions we could come up with predictions, and then when it came through about, we expect this improvement to save X number of lives or $1 million, finance had to verify it, and it went through a multiple step process for finance to sign off on those dollars. Same with lives saved. Sepsis is really the one that you can really, somewhat calculate, these are how many lives that we've saved. Some of the others are more fall into the lives impacted. So if we've screened 10,000 people for colorectal cancer and we catch 10 cancers, you can start to extrapolate out based on population data how many lives you've saved.
And I would just echo what Patrick said. If you've got improvement teams that aren't plugging into finance, that was a huge game changer for us early in our journey, because we were doing improvement work in 2008, and our black belts and master black belts would forecast the savings only to stand up in executive meeting and be challenged by the CFO. All well-intended, but there was always this kind of question mark around the numbers. Are those real numbers? Are they soft dollars? And when Dr. McGill helped to make sure that there was a financial analyst at each one of these cabinets, those questions almost went away immediately. So if you're not investigating ways to partner your finance team with your improvement team, I think that could be a game changer for you all. It was for us.
And one of the things that we've done is started to embed these calculations. Once the finance team has certified or signed off on the calculation, then we can start to embed those calculations in the ClickView apps, so you can see if we improve by this much, this is what it'll do on lives or dollars or other things. We're not big into, or we haven't started down the journey of activity accounting. We hope to launch that later this year and then extend it into next year. So we think that'll help verify, and it'll make it a lot easier to calculate those numbers.
So the next one is, how did you convince the organization to move analytics out of IT?
It was very easy. So we hired a consulting company called Gartner, because you're never a prophet in your own town, and Gartner came in and recommended. So we brought Gartner in because our organizational leadership, our ELT, was very frustrated at the pace that we were delivering analytics, much of what you've heard over the last couple days. And we had a lot of infighting and arguing about what the right way to do or what the right way to go was. And so we felt we just needed an independent third party to come in and give us a recommendation. And that's what the recommendation was.
Okay.
It was more of a cultural assessment than anything else.
Thank you. What are your 7 questions?
Let's go, Travis, see if you know them.
Is this a test?
Yes.
Right. So the first question is, what is the problem we're trying to solve? The second question is around SMART goals. Let me state as the question.
Where do you want to be?
Where do you want to be? The third question is, what are the root causes? The fourth question is, what changes do you have in mind for improvement? The fifth question is, have we applied and measured the changes? The sixth question is, did the change result in an improvement? The seventh question is, did you spread and sustain those changes? And in the playbook, it's, we lay out those questions and it looks very linear, like step 1, step 2, step 3. But in the playbook, we have arrows that if a team or a work group gets through, toll gate 4, which is, what are your ideas for change? They apply those change. The question redirects them back to the third question if it did not result in an improvement. So they make it all the way through that phase. They implemented. They didn't see the results that they thought they would see. It redirects them back to the third question. They might have been working on the wrong root cause. So again, that key takeaway of giving teams grace, we didn't penalize any of these teams making it through the 5th toll gate, and the 6th gate said did it result in improvement. We wanted them to be rewarded to go back through the cycle and just kind of continue that flywheel. So it sounds very linear, but there's key connection points that help teams navigate that and continue that cycle of improvement. So I was close to the 7, probably a B performance, maybe.
Yeah.
Okay.
No, you got them. No, I think that's important though. There was no penalty for failing.
Yeah.
This was more about organizational discipline and organizational culture change.
So in follow-up, how are you ingraining this culture in place to ensure sustainability? Are you partnering with Registry Center at Purdue as part of your strategy?
So I think there's 2 levels to that question. The first one is how are we continuing to spread and sustain? I would say that of the 7 toll gates, the last 2, the last mile, however you want to describe it, are the most difficult. It's still, we have 5 major hospitals, 4 other smaller hospitals, 16,000 caregivers. Getting to all of those and standardizing, each one has its own little culture on the unit and everything else. That's difficult. It's a journey. I think we can do that through showing data and showing the improvements and standardizing tools, et cetera. We have limited engagement with Regan Streif. As we've started to mature our analytics capabilities, we've started to expand partnerships. So Community Health Network is one of the 5 founding members of Indiana Health Information Exchange, which is what feeds data to Regan Streif. We're lucky in Indiana because we have a very mature health information exchange, and we've started to talk about ingesting that data. We do some research. We do research in the organization on a small scale, and we've done some partnerships with Regan Streif on specific research, but I wouldn't say that it's a robust partnership. With Purdue, Purdue has 600 data science students who can get a minor in data science. They can have any major that they want. They call it the data core, data lab. And so we've started to talk to them about how do we attract this talent to keep it in Indiana. It's like a lot of other places. It's hard. Tech talent in Indianapolis is hard to retain.
And internally, there are some programs we have in place to help kind of embed this in our culture. And a couple things are we have white belt, green belt, black belt training that we have available to all of our caregivers that get trained on the framework at different levels. The white belt is offered to all new employees of Community Health Network. They have to take that class within 90 days. And the expectation for every caregiver in the network isn't to be experts in the 7 questions. The white belt training is just introducing them to the 7 types of waste, and we empower them to say, if you see this in your work environment, let us know and we'll help you solve those problems. And then we also, over the last 24 months, implemented a new leadership system that has a new leader onboarding, and we've got a segment of that leader onboarding where we talk about the way we improve. So essentially every new leader coming into the system gets exposure to the 7 questions and the framework that we talked about. And then over the last probably 12 months, there's a Physician Leadership Academy that we train, 30 physicians on different components of leadership. And for the last 2 cycles, Dr. McGill and I have been present to talk about the community way and the way we improve. So those are more internally facing tactics that we have in place to make sure that this stuff is happening culturally. But they've been fairly successful in the amount of people that we've been able to touch through those
It can't be a
programs.
one and done. This
No.
has to be how your organization operates.
It sounds like you really integrated the continuous improvement culture from the very beginning, so that they,
We
you know,
tried
they
to.
start
Yep.
thinking that way from the very beginning.
Yes,
Yeah.
yep.
Okay, so we have time for maybe one more question. It takes a lot to actually realize savings of reduction for things like length of stay. How do you quantify improvements in process/labor-heavy areas like length of stay?
Let me read the last part again.
Okay. Would you like somebody to?
Yeah, who asked the question?
Who asked this question? Do we have a microphone? Here we go. Right.
Give me some color on what you're asking.
Yeah, absolutely.
Because I think it's a good question.
Yeah. I think you were talking earlier about sort of you can sit and calculate all sorts of savings from a analytics and process improvement perspective, and when you put it in front of finance folks, they will just tear it apart, poke holes at it, hard dollars, soft dollars. And one of those areas that really they poke holes at it and really call it mostly soft dollars are kind of length of stay, what we in our organization kind of call labor heavy or process heavy, things that really depend a lot on changing a lot about the flow of patients. I mean, you can reduce length of stay in one area, but if you're shifting volume from one setting to another and you're not really accounting for it from a nursing ratio or making changes to those areas, it's really hard to actually realize those savings. So I'm just kind of curious, what's been your experience? in
Yeah,
that
so
area?
now I understand your question. So that we've struggled with the same thing, and obviously there's been a lot of work on length of stay in general, and so there wasn't a whole lot of meat left on the length of stay. But what we looked at with sepsis was the difference, the delta in level of care. So every patient that we diagnosed earlier that went to the PCU versus the ICU, calculating the difference in the overhead costs to deliver that care. We didn't see, I mean, you can calculate the difference in length of stay, but so the dollars that we showed were, like I said, hard dollars, that we had budget items that we had to meet. So things like length of stay, capacity, throughput, those actually got put into another bucket of what we call soft dollars. We call them gold, silver, and blue. Gold is hard dollars you can take out of the system, so medication, level of acuity of service, things like that. Blue is capacity, throughput, some other opportunities, more of the softer things that finance likes to beat up. We calculate those too. And then what we call blue are either potential savings or shared savings, avoidance of penalties, things that you can put in that bucket that may or may not come back. So of all the improvements that we've done, the one that's had the most impact in the area that you're talking about, the labor-heavy overhead, or is really only sepsis. We've started to calculate it too with CAUTI, CLABSI, SSIs, a lot of those types of things, and it's the same calculation. And part of it was meeting in the middle with what finance would allow and what we knew was going on. So how do we tell the story of the improvement?
Well, I want to say thank you very much. Unfortunately, we are out of time. I want to thank again Dr. McGill and Travis. We'll ask that you